Hello again, class. So, good day to one and all. Today in cardio nursing, we are going to talk about heart failure. This one of the complications that can occur if a patient is suffering from various cardiovascular problems. The end result sometimes can lead to this heart failure. So, what is it? Heart failure, it's the inability of the heart to pump sufficient blood to meet the needs of the tissue. So what is happening here is that the the pumping capability of our heart is not that enough. It's insufficient. The heart in heart failure is weak. It is failing. That's why it's known as heart failure. So it's a clinical syndrome with manifestations of fluid overload or congestion and inadequate tissue perfusion and poor activity tolerance. Because how is the patient going to be active if they lack blood that is circulating in our body? Why do they lack blood? If there is little amount of blood going or circulating the body, it is due to the failing heart. Remember, the blood is delivering oxygen and nutrients to the different parts of the body. If that heart fails, of course, there will be activity intolerance. This can also be referred to as congestive heart failure because of its associated pulmonary and peripheral congestion, or cardiac decompensation, cardiac insufficiency, or even ventricular failure. Those are the other names. But we are commonly calling it HF or heart failure. Classifications of this. We have left versus right. Like what we had during our previous discussion, I have already given you the preview of the left-sided heart failure. So this one, it's a condition that impairs the left ventricle's ability to pump blood into the aorta and the systemic circulation. So remember, the left side of the heart, or the structure before the left side of the heart, are our lungs and the pulmonary veins. So if the left ventricle is too weak to pump out blood into the aorta, tendency for the blood is to go back. It will backflow or it will remain stagnant. So if the lungs cannot give, or it cannot cause the blood to move due to the failing left ventricle, what happens here is that the fluid from the blood will accumulate instead inside the patient's lungs. That's why most of the signs and symptoms of left-sided heart failure will exhibit pulmonary signs and symptoms. What are they? We've already discussed this before, but I will just recall them. We have dyspnea, shortness of breath. You can auscultate crackles in the patient's lung fields. What else? There is pink, frothy sputum, and they have a productive cough. These are the left-sided heart failure signs and symptoms. It's primarily pulmonary. So if you can see that the patient is having shortness of breath, they are having difficulty of breathing, and you can see that they have thick frothy sputum, most likely the patient has left-sided heart failure. Now we go to the right-sided heart failure. So the right ventricle fails to pump blood into the pulmonary artery. This is the one that goes to our lungs and into the pulmonary circulation. So what happens here is the blood tends to go back. Where? Go back into the vena cava, to the system, to the veins, going back to the other organs of the body. So if the right side is too weak to pump blood into the pulmonary artery going towards the lungs, it will go back. So what are the organs attached to the vena cava? You have our the blood vessels coming from the extremities, the GI organs, like the liver. So you are going to expect systemic signs and symptoms. So if you can see that the patient has edema of the hands and feet, even the face, that's right-sided heart failure. If there is splenomegaly, again right-sided. That's the enlargement of the spleen. If the patient has hepatomegaly, that's the enlargement of the liver. That's again right-sided heart failure. You can see that the jugular veins are also distended in the patient who has right-sided heart failure. And since there is too much pressure building up in the vena cava because of the pooling of blood, since blood cannot advance into the pulmonary circulation, tendencies for it to go back into the liver, this pressure now is going to cause hepatic hypertension. And with this hepatic hypertension, if the liver cannot take that much blood, tendency is for the fluid in the blood inside the liver to leak out of the liver. If that leaks out from the liver, there will be pulling of fluid into the patient's abdominal cavity, leading now to ascites. And once that happens, the abdominal girth of the patient is going to increase. So you can see that the patient's abdomen is enlarged. That's one of the signs of right-sided heart failure as well, because of the pooling of fluid that has been leaking from the patient's liver. So as you can see, the various structures here of the heart, we have the right side and the left side. If both of these ventricles fail, blood will go back to where it was coming from the lungs in the left ventricle, from the system in the right ventricle. Now we go to backward versus forward. It's according to the direction of blood flow. Backward failure, it involves the retrograde flow of blood back to either the pulmonary or the systemic circulation. So it goes back, like what I've been talking about for the past few minutes. Or there's forward failure. It's the inability of the ventricles to pump blood forward into the systemic and pulmonary circulation. So tendency is for the blood to be stagnant in those structures, because it cannot move the blood forward because of the weak ventricles. We also have high output versus low output. For the high output failure, despite normal or high cardiac output, the heart cannot cope with the needs of the body. So it's either normal or high, but still the heart is still failing the oxygen and nutrient needs of the body. Or there's low output failure due to poor ventricular contraction that leads to decreased cardiac output. This is the more common one, wherein due to the weakness of the ventricles, it just pumps like this, it is going to cause a low output or low cardiac output. And we also have acute versus chronic. Acute heart failure. This is a sudden change in the heart's ability to contract, and it can cause life-threatening symptoms and pulmonary edema. Acute meaning it happens immediately. It abruptly occurs. While for chronic heart failure, this occurs when the patient has a pre-existing disorder or a chronic disease, which gradually compromises the heart's ability to pump effectively. So it is progressive. It's the heart failure of the patient now is a complication of that pre-existing disorder or disease. Let's say, for example, the patient has congenital heart disease. If that is left untreated, it will ultimately lead to heart failure. Like we're going to discuss more of this later on once we go through this concept or on this subject. Now we go to systolic and diastolic heart failure. This is, of course, according to the ventricular functioning. Systolic heart failure, this is the inability of the ventricles to adequately contract and pump blood. So, in systolic heart failure, it's not contracting that much. It is weak. But for diastolic heart failure, this is the inability of the ventricles to completely fill because the ventricles are stiff, maybe due to scarring or whatsoever. They become stiff, so they do not contain the right amount of blood that they should contain. So tendency is for the patient to have a low cardiac output. The end diastolic volume should be around 120 ml, while the end systolic volume should be at 50 ml. And anything lesser than that, probably the patient is experiencing heart failure. The etiology of heart failure, number one, abnormal preload and afterload conditions. Two, abnormal cardiac muscle functions. And three, limited ventricular filling. So these can be the causes of heart failure. So either the preload or the afterload volume is somehow affected. We're talking about the blood that is coming in and out of the ventricles, or of course the myocardium of the heart. There's something wrong. Maybe it's scarred, maybe it's diseased or whatsoever, and limited ventricular filling due to stiffening. Now we go to the pathophysiology of heart failure. So here, what happens is um, this is it starts with the activation of the compensatory mechanisms of the heart. So it increases the heart rate. It increases the size and strength of ventricular muscle. So at first, if the heart senses something wrong with the body, it compensates. So it will increase the heart rate, and at the same time, it will struggle. It will make the heart do more. It will use that much strength to pump out blood from the heart. And there's increased ventricular filling capacity as well to cope up with that problem. Others brought about by the activation of the sympathetic nervous system. Remember, once the sympathetic nervous system is always activated, there will be release of the catecholamines. What are the catecholamines? These are the epinephrine and norepinephrine. So if you're always constantly stressed out, this can contribute later to this. Because once we are stressed, there's constant release of catecholamines, which is bad for the body. Because these catecholamines, they can increase our vital signs. So if it increases the vital signs such as the heart rate, the pumping ability of the blood, the heart, this will be bad for the heart later on. It can lead to heart failure. Or shunting of blood brought about by congenital heart defects, like left to right shunting, right to left shunting, brought about by atrial septal defect or ventricular septal defect. Or also the stimulation of the renin angiotensin aldosterone system. If you can recall your nutrition, we've discussed all about this regarding the decreased, if the body constantly detects a decrease in blood pressure, the renin-angiotensin-aldosterone system is going to be activated. The end result of constant stimulation of this system will lead to hypertension because of the production of aldosterone and angiotensin 2. That's the end result of the activation or stimulation of the RAAS or the renin angiotensin aldosterone system, or shifting to anaerobic metabolism can be caused by this if there's lack of oxygen in the body. So cardiac output now is no longer maintained. Left-sided heart failure can occur. So since it cannot forcefully contract to eject blood into the aorta, there will be decreased cardiac output, decreased organ tissue, and cellular perfusion. So the organs of the body cannot receive that much oxygen and nutrients. While there will be congestion of blood in the left ventricle. Then, also in the left atrium, also in the pulmonary veins, and the blood will be stagnant in the lungs because it cannot move forward due to the weakened left ventricle. So, tendency is to have pulmonary edema. There will be impaired gas exchange, and carbon dioxide will accumulate in our blood. Now, signs and symptoms of pulmonary congestion will be manifested by the patient, like the ones I've mentioned earlier: crackles, dyspnea, shortness of breath, faint frothy sputum, and so on. Now we go to right-sided heart failure. Since the heart or the right ventricle cannot forcefully contract, it will no longer eject blood into the pulmonary artery. Tendency is to have decreased blood flow to the lungs and decreased blood to be oxygenated, since the lungs is the one giving oxygen to our blood. And also, there will be congestion of the blood in the right ventricle, right atrium, the vena cava, and the venous systemic vasculature. This now will lead to systemic congestion. The signs and symptoms of systemic congestion would be the ones I've mentioned earlier: the edema, the face, the hands, the feet, splenomegaly, hepatomegaly. You have distended jugular veins, ascites. So, condition with for left-sided for cor pulmonale, this is a condition in which the core, is affected by lung damage. This can sometimes occur due to respiratory disorders such as COPD or bronchiectasis. Since the patient has COPD, the patient here is not able to take in that much oxygen, so there's impaired gas exchange. Tendency now is there will be an accumulation of carbon dioxide in our blood. If that happens, since the lungs cannot give adequate oxygen to the blood, tendency is that there will be constriction of the pulmonary artery. Constriction of pulmonary artery. And if that happens, there will be pulmonary hypertension now. Since it is constricted, how is blood going to flow into the pulmonary arteries? Remember, the pulmonary arteries are the ones that is giving blood to the lungs in order to collect oxygen. But if this is constricted, if the patient is suffering from pulmonary hypertension, tendency is the blood will go back. Where? To the right ventricle. That's why there will be an increase in the workload of the right ventricle. If that happens, like any muscle of the body, the skeletal muscles, if there is an increased workload, it is that muscle is going to hypertrophy. So it will now lead to right ventricular hypertrophy. But remember, hypertrophy of the myocardium is not normal. It is abnormal. Hypertrophy of the skeletal muscles is normal if you are working out. But for the myocardium, it is not. that will ultimately lead to now a right-sided heart failure. That is what cor pulmonale is all about. Cor pulmonale is brought about by chronic lung disorders leading to heart failure. That is what cor pulmonale is. So that's these are one of the causes of heart failure. So here are the following. Aside from the things that I've mentioned earlier, for right-sided heart failure, you also have increased intracranial pressure, leading to irritability and confusion. For the left-sided heart failure, you can place the patient in an orthopnic position because it can be relieved. Their dyspnea can be relieved by placing them in a high Fowler's position. There's restlessness, of course, if you lack in oxygen, anxiety, fatigue, there's weakness. There's also decreased urine output for left-sided heart failure. You can see that the patient looks pale, cool, clammy skin. There's tachycardia, increased blood pressure as well, and chest pain sometimes is felt by the patient. So as you can see here, there's edema of the feet. Patients who have heart failure may need oxygen therapy. And this is the orthopnic position that you are going to place the patient in. The jugular veins are seen in patients who have right-sided heart failure. This one, hepatomegaly, can be observed through ultrasonography. And you can see here, this brought about by left-sided heart failure, chest pain, or difficulty of breathing. This one now is ascites, the enlargement of the abdominal girth due to the leakage of fluid from the liver brought about by hepatic hypertension. So these are the different signs and symptoms of heart failure: shortness of breath, swelling of feet and legs, chronic lack of energy. There's difficulty due to breathing problems, swollen or tender abdomen with loss of appetite that's brought about by ascites, cough with frothy sputum seen in left-sided, increased urination at night, and of course confusion and impaired memory. How are they diagnosing heart failure? They use ECG or stress tests to determine how um, how bad the heart of the patient has. Echocardiogram to visualize the heart structures. Radionuclide angiography can be done as well. So with this, our nursing responsibilities with nuclide angiography is to let the patient take in or assess it rather for any allergies in the contrast medium that the patient is going to take in. Chest x-ray can be done. Serum electrolytes are also monitored in the patient. Cardiac catheterization will also be done in order to perform myocardial biopsy to assess for any abnormalities in the myocardium of the patient, and pulmonary function studies, especially for those who are suffering from chronic lung diseases. So this is an example of an echocardiography with congestive heart failure. This is radionuclide imaging. So chest x-rays. You can see here there's cardiomegaly. So here are other tests that are done. So medical management. Objective is number one, to eradicate or reduce any etiologic contributory factors to heart failure, especially those which are modifiable and are curable. So if the patient has any pre-existing disease, such as congenital heart disease, or the patient has A lung disease. These things should be treated beforehand, or if the patient has infection of the heart, they need to be treated in order for heart failure to be avoided, since these are, heart failure is a complication of those diseases. We need also to reduce the cardiac workload of a patient who has heart failure. So, patient will be in total bed rest for patients having heart failure. And prevent further myocardial damage by dietary modifications. So, low sodium is given to the patient. So, advise the patient not to take in salty foods. Fluid restrictions as well if the patient is suffering from any congestion or edema. So you need to monitor the patient's fluid intake. Lifestyle changes. Avoid smoking, alcohol, and caffeine. So most especially those who are chronic smokers, they need to avoid having that because that can later on lead to a chronic lung disease, leading or causing heart failure later on. Sedentary lifestyle as well. So when we talk about sedentary lifestyle, these are people who hate exercise. What they do is they love eating, and after they eat, they just slouch about. They just spend their time. They're just spending their time in their couches or in bed watching TV. So you need to teach the patient on how to do proper exercises. They should have an exercise program. We shouldn't be having a sedentary lifestyle. Our lifestyle should be active with exercise, and the diet should also be a balanced diet. Anti-embolism stockings are also given to patients to prevent the formation of an embolus inside the patient's legs, because this can lead later on to um, a pulmonary embolus. Drugs are the following. We need to administer oxygen, most especially to patients who are suffering from shortness of breath or dyspnea. Diuretics can be given, such as Lasix, to lower down the blood volume. Inotropic drugs or cardiac glycosides are given, such as digoxin. Take note, when we give digoxin or lanoxin, the brand name, we need, our nursing responsibility is to always assess for toxicity. And if the patient is suffering from digoxin toxicity, if the patient is complaining of visual disturbances such as yellow halo around lights, you need to stop the digoxin therapy immediately and give Digibind, which is the antidote to digoxin. Sympathomimetics are also given. What are sympathomimetics? That's why they are called sympathomimetics, because they imitate the stimulation of the sympathetic nervous system. This will cause the heart to pump effectively. Vasodilators are also given in order to dilate the constricted arteries or blood vessels. We'll run through the different surgical treatments later on. Now, with the heart failure medical management, I need you to remember this mnemonic: dad bond clash. I repeat, dad bond clash. What does it stand for? D stands for digitalis. So digitalis, this is digoxin. This increases the force of myocardial contraction, which I've been talking about earlier, and slows the conduction of or through the atrioventricular node. It improves contractility, so instead of the heart contracting like this, it will cause the heart to pump in this manner. It will pump effectively with digitalis therapy. So it will increase the left ventricular output and enhances diuresis. So if the left ventricle is weak, you expect that there will be decreased urine output as well. ACE inhibitors, the drugs that are ending in pril, captopril, enalapril, april. You always remember that. APRIL. So ACE inhibitors, they promote vasodilation and diuresis by decreasing the afterload and preload, ultimately decreasing the workload of the heart. So ACE inhibitors can also be given. Dobutamine, which is an example of a sympathomimetic. When we say sympathomimetic, again, it imitates, it mimics the sympathetic nervous system activation. So this is an IV medication administered to patients with significant left ventricular dysfunction and hypoperfusion, which stimulates the beta-1 adrenergic receptors. Beta blockers are given. These are drugs ending in olol, like propanolol. So this reduces mortality and morbidity in heart failure by reducing the adverse effects from constant stimulation of the sympathetic nervous system. Oxygen therapy, like what I said, because of dyspnea or pulmonary congestion. Nitrates, nitroglycerin, which is a drug for angina pectoris. They are also given to patients because they can cause venous dilation, which reduces the amount of blood return to the heart and lowers preload. Again, digitalis can be given to remove excess extracellular fluid by increasing the rate of urine produced in patients with fluid overload. Calcium channel blockers, the one ending in dipin, amlodipine, they cause vasodilation as well. Remember, calcium channel blockers, beta blockers, and ACE inhibitors are drugs used to treat hypertension. They can also be given to patients with heart failure because they also have signs and symptoms of hypertension. So causes vasodilation and reducing systemic vascular resistance. Lifestyle changes, which I've mentioned earlier. Angiotensin 2 receptor blockers can also be given. Again, these medications, angiotensin 2 receptor blockers, are used to treat hypertension as well. And they block the effects of angiotensin 2 at its receptor sites. Remember, with the renin-angiotensin aldosterone system, angiotensin 2 will cause the blood vessels to constrict. But if you give angiotensin 2 blockers, they will cause, or they will not cause, they will block rather the angiotensin 2 and will have the same hemodynamic effect of the ACE inhibitors. So they serve as alternative for patients who cannot tolerate ACE inhibitors. So remember, for angiotensin 2 receptor blockers, they always end in the suffix sartan, like candesartan, losartan, eprosartan, and the like. So remember that. For ACE, pril. Beta blockers, olol. Calcium channel blockers, dipin. Angiotensin 2 receptor blockers, sartan. Sodium restriction. So it should only be around 2 to 3 grams of sodium per day. And avoidance of drinking excessive amounts of fluid as well. And lastly, a potent vasodilator, hydralazine, can be given because it also lowers systemic vascular resistance and left ventricular afterload. So remember this neuronic dad bond clash. Now, these are the surgical treatments for patients who have heart failure. First, we have cardiac resynchronization therapy. This is a treatment to help the heart beat with the right rhythm. And here, it uses a pacemaker to restore the normal timing pattern of the heartbeat. So the CRT pacemaker coordinates how timing of the upper heart chambers, which are the atria, and the lower heart chambers. So in CRT, it helps create the correct rhythm in the heart for patients who are suffering from heart failure. So it looks like this. So these this device is inserted into the subcutaneous skin of the patient. And as you can see, there are leads leading into the atrium and ventricles of the heart. This will help with the timing of the patient's heartbeat. Another is intra-aortic balloon pump, the IABP. Again, this is a mechanical device that helps the heart pump blood. And this device is inserted into the aorta, which is the largest artery in the body. It is a long, thin tube called a catheter with a balloon on the end of it. So it looks like this. So here, the descending aorta is used, and the balloon is inflated at the onset of cardiac diastole and deflated at the onset of systole. That is the IABP. So it will help the heart pump blood. Another is the ventricular assist device, or the VAD. It is another mechanical pump that's used to support heart function and blood flow in people who have weakened hearts. So this device takes blood from the lower chamber of the heart and helps pump it into the body and vital organs, just like a healthy heart would. So it looks like this, the VAD. So it will take blood from the left ventricle and pump it to the rest of the body. It's, as you can see here, it's attached to the left ventricle and attached to the aortic arch. So it assists in pumping out blood into the aorta. So there you go. It looks like that. It is attached to the patient's body again. Another is by doing heart transplant, which I've mentioned earlier. As you can see here, they are, just to keep this short, since we're no surgeons, they may use the cardiac tissue from a donor in order to remove the weakened ventricles and replace it with a newer one, a healthy one, so that the patient's heart can pump effectively. Or they do this as well, wherein they connect two hearts. So this is the artificial type of heart transplant. So this is a newer device that can be used to treat heart failure until eventually the patient is going to be needing a heart tissue from a donor. What are our nursing responsibilities for patients who have heart failure? We need to provide adequate oxygenation. If the patient is having trouble breathing, we need to position them properly in an upright position, high Fowlers. We need to promote balance between rest and activity. So if the patient or the doctor said activity restriction, they should be restricted with it. If they have worst type of heart failure, they should be in complete bed rest. There should also be a decrease in anxiety and stress level. So they shouldn't, or if they have a spouse, the spouse shouldn't stress the patient that much. Facilitate fluid and electrolyte balance as well. So if there's sodium restriction, we need to enforce that to the patient. If there's fluid restriction, we need to enforce that as well. And provide proper skin care, most especially for patients who have edema, because there will be skin breakdown if the patient is suffering from edema. Provide them with lotion to prevent breakdown from happening, and promote proper nutrition and elimination as well. We need to tell the patient to avoid foods that are high in sodium. So they should avoid salt or salty foods. like canned goods, since it's high in sodium. Also, chips, peanuts that are highly seasoned with salt. We should avoid those. And facilitate learning through health teachings. So, teach about diet, teach about exercise, especially those who have pre-existing conditions that can ultimately lead to heart failure. We need to emphasize proper nutrition and exercise to these patients in order for them to avoid having heart failure. Or those who have vices such as smoking as well. We need to emphasize to the patient how bad smoking is for the health. And administer medications as prescribed and monitor the patient's response. So if we're giving any medications, like say for example, the antihypertensives, we need to check first their blood pressure prior to administering them, especially the potent vasodilators. And we need to check for their adverse effects as well, most especially when giving digitalis drugs such as digoxin, and assess in medical and surgical diagnosis and treatment. So if they will undergo different forms of diagnostic procedures. You already learned that before with my previous lecture about diagnostics. Please remember our nursing responsibilities during each diagnostic procedure. And with the post-op care after heart transplant, we need to watch out for bleeding. If the patient is bleeding, we need to report it immediately. And we need to administer immunosuppressive agents. Usually for patients who have undergone heart transplant, immunosuppressive therapy is done within the next 6 to 12 months. Now, one of our patient teaching in a patient who's taking immunosuppressive agents is, since these are immunosuppressive agents, these agents will help prevent rejection of the transplanted heart into the patient, because the body is going to detect that this is something foreign. The heart is foreign, which really is foreign. So tendency is for the body's immune system to attack the foreign heart. In order to stop that from happening, we are going to administer immunosuppressive agents. But we need to teach patients taking immunosuppressive agents to avoid any situation that can cause them an infection, or that can cause infection to the patient, since these immunosuppressive drugs will really depress or suppress the patient's immune system. So tendency is for the patient to be exposed to various forms of infection. So in order to teach them not to be infected with any type of infection, we need to teach them to wear a mask at all times, avoid going to crowded places, avoid eating raw fruits and vegetables, since they can get an infection from that, and avoid people who have obvious infection. So they should be isolated during immunosuppressive therapy. So after the recovery, the patient must remain under medical supervision and should continue taking digitalis, diuretics such as Lasix. When giving Lasix, one of our nursing responsibilities with Lasix or would be to monitor for the potassium levels, since Lasix is a potassium wasting diuretic. So potassium supplements can be prescribed to patients who are taking Lasix. So that's it, everyone. Regarding failure, thank you very much for listening for today's lecture about heart failure. If you have any questions about today's lecture, please do not hesitate to message me about them. So again, thank you very much for attending today's lecture on heart failure, and have a great day.